Okay, all welcome back. We're going to have a look at the knee now. We're going to look at the bony landmarks and also the muscles that control movement from the knee and the leg. Keeping in mind that a number of those muscles actually cross the knee itself. Excuse me, for example, gastrocs. And also actually cross the ankle as well. So some of those muscles will have function and affect both the knee and also the ankle joint. All right, so let's get underway. So what do you need to be able to do following this particular part of the lecture? Identify the bony landmarks of the knee and the anatomical structures attaching to them, and that's essentially ligaments and muscles. The main muscles involved in the movement of the knee and the peripheral nerves. You actually need to know what nerves are innervating these muscles on this particular occasion. The popliteal fossa and muscles in each compartment of the leg. So there's three different compartments of the leg. Anterior, lateral and posterior is made up of two subcompartments, one superficial and one deep. All right, so landmarks of the tibia itself. So this is an anterior view. So this is tibia here and fibula, tibia and fibula, and anterior view and posterior view. It's worthwhile keeping a couple of things in mind. Fibula is is narrower at the proximal end than it is at the distal end. That's fibula, and the tibia is actually typically wider and larger at the proximal end, less so at the distal end. So that does help you on a view to be able to orient which section you're looking at. So for example, if you just get the distal section and you're told that it's a distal section, then you are able to ascertain which is fibula and which is tibia. All right, so lateral condyle, I've mentioned already, so lateral condyle, medial condyle. So the lateral condyle is the lateral portion of the proximal tibial plateau, and it obviously articulates with the lateral femoral condyle. The medial condyle, so lateral condyle, medial condyle, and then obviously, given that it's a posterior view, medial condyle and lateral condyle. The medial condyle is the medial portion of the proximal tibial plateau, which of course then articulates or joins with the medial femoral condyle. The intercondylar eminence is the raised ridge between the condyles. It provides the attachment for the cruciate ligaments, and we're going to talk about the cruciates as we move our way through, and also the meniscus, remembering that the knee joint, synovial joint, but there is also a fibrocartilaginous disc that sits in between the femur and the tibia. The tibial tuberosity, which you can only see anteriorly, so it's the anterior bony prominence below the condyles, and it is the insertion of the patellar ligament. Now, the patellar ligament sometimes gets referred to as the patellar tendon, and so if it gets referred to as patellar tendon, then we talk about a suprapatellar tendon and an infrapatellar tendon, but the use of ligament is also appropriate as well. The shaft of the tibia down through here, shaft of the tibia down through here, has an anterior bony prominence below the condyle. Sorry, I apologise. Is the long central body of the tibia between its proximal and its distal end, so that the whole shaft down here and the whole shaft down here. The interosseous border is this area between the fibula and the tibia, right? Interosseous border. And it's actually covered by, and we'll look at this in a minute, it's actually covered by a membrane, which is referred to as the interosseous membrane. The popliteal line should be superior and posterior. It is, and that is the diagonal ridge on the posterior proximal shaft. And it's the attachment of the popliteus muscle. So the popliteus muscle attaches in here. The medial malleoli So I'll move that up here. So we talk about a medial malleoli and a lateral malleoli. The medial malleoli, it's often referred to as your ankle bone. The medial malleoli is obviously on the tibia, and the lateral malleoli is the fibula. So distal tibia, distal fibula. And then there is a malleolar sulcus, that's on the posterior view. That's the groove on the posterior medial malleolus for the passage of the tibialis post, tib post, and flexor digitorum longus tendons. Fibula notch, also distal on the tibia, and that can be seen posteriorly. Is the concave surface on the distal lateral tibia that articulates with the fibula. So the fibula notch. So it's essentially where the fibula actually articulates with the tibia itself. As far as the fibula goes, we talk about a fibula head. So obviously you can see that both anteriorly and posteriorly. It's a proximal projection that articulates with the lateral tibial condyle, not the femur, right? So tibial condyle, so the articulation between the fibula and the tibia is here. There is no articulation. So there's a proximal articulation and a distal articulation, but there's no articulation between the fibula and the femur. The neck is narrowed just below the head, and the common fibular nerve actually wraps around it. And then finally, as I mentioned, the lateral malleolus is a part of the fibula, and it's the distal projection forming the lateral wall of the ankle. Okay, so they're the bony landmarks of the tibia and the fibula. Together we refer to the tibia and the fibula as the leg bones. So anything below the thigh is referred to as the leg bones. Okay, now let's move on to the muscles of the leg. As I mentioned, there's three compartments: an anterior compartment, a lateral compartment, and a posterior compartment, which is made up of two groups, a superficial group and a deep group. So we talk about three compartments, but that posterior compartment is made up both of a superficial and a deep. In the anterior compartment, you need to know these innervations, right? It's the deep fibular nerve that innervates the anterior compartment. We're going to go through these muscles individually in just a moment. We talk about, there are four muscles that are listed within the anterior compartment: tib anterior, extensor hallucis longus, extensor digitorum longus, and fibularis tertius, often referred to as peroneus tertius. So those two terms can be used interchangeably. All right, so let's have a look at that anterior compartment. So we'll start, remember, it's the deep fibular nerve that innervates the anterior compartment. They are primarily dorsiflexors. Now, what a dorsiflexor is a reference to the ankle and the movement of the foot in relation to the tibia. If the foot approximates the tibia, we refer to it as dorsiflexion. If the foot moves away from the tibia, we refer to it as plantar flexion. So most of these anterior compartment muscles are in fact dorsiflexors, but they also have secondary functions. I shouldn't say that. Many of them have secondary functions. So as far as tib anterior goes, it originates on the tibia, obviously. So lateral aspect of the tibia to the medial aspect of the foot. And as a result, not only does it dorsiflex, but it turns the foot in, and that's known as inversion. If the great toe moves towards the midline, it's referred to as inversion. If the great toe moves away from the midline, it is referred to as eversion. Still in the anterior compartment and still the deep fibular nerve, extensor hallucis longus. And as you can see, from the mid shaft of the fibula to the great toe, and as a result, it's going to extend the great toe. So the same principle applies. Sorry, I apologise. The principle of extension of the toes is the same as it is for dorsiflexion of the foot. In other words, if the big toe is moving towards the tibia, then we talk about that movement as being extension. If it moves away, we talk about it being flexion. So extensor hallucis longus. Hallucis means big toe, and it is as it sounds. It extends the big toe, and it's a longueur muscle. The implication being is that there is a brevis, which there is, but extensor hallucis longus extends the great toe and assists in dorsiflexion of the ankle. I apologise. Yep, extensor hallucis longus. Extensor digitorum longus is from the tibia and goes into the distal phalanges of digits 2, 3, 4, and 5. Right, so digits 2 to 5. And we'll do the same thing. It will dorsiflex the ankle and it will extend digits 2, 3, 4, and 5. Fibularis tertius or peroneus tertius from the fibula into the fifth metatarsal. So it's going to be a dorsiflexor and everter, right? Remember I said to you if the great toe moves towards the midline, it's inversion. If the great toe moves towards the away from the midline, we refer to it as eversion. And fibularis longus, fibularis longus from the lateral fibula into the base of the first metatarsal and the medial cuneiform on the bottom side of the foot. Now, so as a result then, fibularis longus runs posterior to the lateral malleoli and goes inferior to the foot and inserts into the first metatarsal, and the medial cuneiform on the bottom of the foot itself. So I'm sure you can see what this is going to do. It's going to plantar flex because it runs posterior to the lateral malleoli, and it will evert the foot as well. And then there's that fibularis brevis or peroneus brevis, which I mentioned before, from the lateral surface of the fibula into the lateral tubercle at the base of the fifth metatarsal. And again, it runs posterior to the lateral malleoli, so it's going to be involved in plantar flexion and eversion of the foot. Gastroc, so now we're on the posterior aspect of the leg. Note that there are two heads to gastrocs proximally, so I didn't mention innervation. I apologise about that. So we know that the lateral compartment is innervated by that superficial fibular nerve. The anterior was innervated by the deep fibular nerve. The lateral compartment innervated by the superficial fibular nerve. And then the posterior compartment, now remember I mentioned that there is a superficial and a deep group. The posterior compartment is innervated by the tibial nerve, and most of these muscles are plantar flexors for fairly obvious reasons. They start posteriorly, and the majority of them finish posteriorly as well, into the calcaneus, for example, for gastrocs. Okay, so gastrocs, medial and lateral condyles of the femur, so medial condyle of the femur, lateral condyle of the femur, and then via the Achilles tendon, also known as the calcaneal tendon, which inserts into the calcaneus, and obviously that then means that it is going to plantar flex the foot. Now, because it crosses the knee, it's also a weak flexor of the knee, right? Strong plantar flexor of the ankle and the foot, weak flexor of the knee joint because it crosses both joints. Soleus or soleus is deep to gastrocs, so we're in the posterior compartment, superficial group, and so tibial nerve innervation. But soleus doesn't cross the knee joint, therefore it doesn't have effect at the knee joint, but it does also insert into the Achilles tendon or the calcaneal tendon, which then goes into the calcaneus. So it's involved in plantar flexion of the foot, of course. All right, plantaris is this really bizarre muscle, and it's only up until recently that there's been a clear idea about what its likely function is, and it's not actually mentioned here, but you can see that it actually starts proximally. So it's from the lateral supracondylar line of the femur, so you just need to remember femur. And then it runs in a really thin band of striated tissue down into the posterior surface of the calcaneus. So as you can see, it's going to be a very, because it's not a big muscle, weak flexor of the knee and a weak plantar flexor. As a result, because of the size of this muscle, or lack thereof, there's been a lot of speculation about its function. And in the recent period of time, it's believed that it's more proprioceptive. That is, that it provides feedback to the central nervous system about the position of the knee and position of the ankle, in other words, the foot as it relates to the tib and the fib. And so that positional sense is referred to as proprioception. Popliteus, I mentioned the popliteal line before. Innervated by the tibial nerve. So now we're into the deep group. So, sorry, I apologise. We had three muscles that were in that superficial group, gastrocs, soleus and plantaris. Now we're into the deep group. And the deep group obviously sit deep to the superficial group. Popliteus, from the lateral condyle of the femur into the posterior surface of the proximal tibia. And as a result, I'm sure you can see that when this contracts, it will internally rotate the tibia. And this is known as unlocking the knee. Now, there's a specific action which you'll look at later in biomechanics, but essentially it unlocks the knee by laterally rotating the femur on the tibia. A better way to think about it is medially rotating the tibia underneath the femur. Deep group, flexor hallucis longus, also the tibial nerve, and it is going from the posterior surface of the fibula into, and you can't really see it all that clearly, and I don't know why they haven't run this in green, but into the plantar surface of the distal phalanx of the great toe. So it runs all the way down here, and as a result, it flexes the large toe, and it's the long muscle, right? So it's coming from well outside of the ankle and or foot itself. So it flexes the great toe and assists in plantar flexion. Still the posterior compartment, deep group, tibial nerve, flexor digitorum longus from the medial aspect of the posterior surface of the tibia, so the posterior surface of the tibia, into the bases of the distal phalanges of digits 2, 3, 4, and 5, and therefore plantar flexes the foot and also flexes the digits as well. Tib post or tibialis posterior, again, posterior compartment, deep group, tibial nerve, and its origin is the posterior tibia. Now, it runs down behind the medial malleolus, right, posterior to the medial malleolus, and therefore it's going to be involved in plantar flexion, but also because it attaches to the plantar surface of the medial tarsal bones, will invert the foot. As far as ligaments of the knee go, we're going to have a look at anterior and posterior cruciates, medial and lateral, collateral ligaments, so they're obviously in the knee, as is the transverse ligament and as is the posterior meniscofemoral ligament as well. Okay, the anterior cruciate. Now, when we talk about the position, when we make reference to the cruciates, we talk about location as it pertains to the tibia, right? So what does that mean? If we're talking about the anterior cruciate originating on the anterior, so inserts onto the anterior intercondylar area of the tibia. So anterior cruciate to the anterior aspect of the tibia, right? And so this is an anterior view. So these are your, this is the patellar groove here, obviously for the patella. This is fibula head. This is tibial tuberosity in here. And this is the anterior aspect of the tibia, and it connects to the posterior aspect of the femur. Now, as a result then, what it will prevent is the femur moving posteriorly on top of the tibia. Or the other way of looking at that is it prevents the anterior movement of the tibia underneath the femur. And then, of course, the opposite of that is the posterior cruciate ligament, posterior to the posterior intercondylar area of the tibial plateau. So it's into the posterior aspect of the tibia and therefore to the anterior aspect of the femur above. And I'm sure you can see the role of this. It prevents the tibia moving posteriorly underneath the femur, or the femur moving anterior to the tibia. The medial and lateral collateral ligaments are as they sound. One is lateral to the knee, one is medial to the knee, and they run from the either the lateral or the medial epicondyle down into the tibia itself. And what they will do, if we just look at the medial collateral ligament, the medial collateral ligament stabilizes the knee against lateral forces to the knee, whereas the lateral collateral ligament will stabilize the knee against medial forces to the knee, right? Stabilizes the femur against, well, both tib and fib, but let's go for tib. Stabilize the femur and tibia against a medial force. The transverse ligament is as it sounds. It attaches to the meniscus. So this is the meniscus that sits between femur and tibia. And the meniscus essentially is there to decrease the friction forces between the femur and the tibia. Now that meniscus is thinner in the middle than it is laterally and medially. We're obviously looking at a right knee here, anterior, so lateral and medial. And that ligament, the meniscus is thinner in the middle. So this transverse ligament stabilizes the lateral meniscus and the medial meniscus. So it connects the front of the lateral meniscus to the front of the medial meniscus and creates stability for the meniscus. And then the last ligament is the posterior meniscofemoral ligament, which is, as it sounds, it goes from the femur into the lateral meniscus. This is a posterior view, the lateral meniscus in the knee, and therefore stabilizes the femur against the meniscus and the meniscus against the femur. The last thing I want to make mention of here, and I need to move this around for a little bit, is what is known as the popliteal fossa. Now, the popliteal fossa is this area formed at the posterior aspect of the knee and laterally and superiorly made up of semimembranosus. Sorry, I apologise. Got plantaris and biceps fem. Lateral head here, so that's medial. So that's right, yes, medially, proximally is semimembranosus, is one border. Medially and distally is the medial head of gastrocs. Superiorly and laterally is the biceps femoris. And inferiorly and laterally is the lateral head of gastrocnemius. Now, internal to that is plantaris. That creates what is known as a popliteal fossa. So you've got to remember those boundaries. And inside the popliteal fossa, the reason we talk about it is it has clinical significance because it carries the following component contained within here: the tibial nerve, the common fibular nerve, the posterior cutaneous nerve of the thigh, the popliteal vein and their tributaries, the popliteal artery and their branches, and the popliteal lymph nodes and lymphatic vessels, and the popliteal fat pad as well. So you're going to need to remember that one. All right, I'll finish there. Thank you.